Yes, Ms Walker.
Thank you, sir. As Ms Jones explained in her introduction, I will be addressing you on the fourth and fifth of our 6 key themes. First, haemovigilance, and then diagnosis and the lack of treatment for those who contracted an infection. In relation to haemovigilance, we submit that there was no adequate haemovigilance system in England and Wales before the mid-1990s, and there are still considerable problems with the operation of the system that exists today. We consider that this inquiry is in a unique position to make detailed recommendations, not just to address the failures of the past, but also those that are ongoing and continue to pose a risk to patients. When we talk about haemovigilance, we mean the systematic surveillance of adverse reactions and adverse events related to blood and blood products, with the aim of promoting the safest possible practice and best possible outcomes for patients. This embraces provision of education and advice needed to achieve that level of safety and...
Just ask you to slow down
Sure,
a little,
of course.
for the sake of the stenographer.
Of course.
Take your time.
This embraces provision of education and advice needed to achieve that level of safety and the audit of clinical practice against best practice guidelines. An effective haemovigilance system involves a process of learning when problems are identified, resulting in modifications to policies, standards and guidelines, as well as improvements to processes and blood services. For example, measures to improve the ultimate safety of blood, such as testing or donor exclusion. While the blood services are plainly the best equipped to coordinate this system, there are many other relevant stakeholders: the government, other NHS bodies, regulators, and professional societies. Whilst we note the submissions made on behalf of NHSBT about the current haemovigilance system, we suggest that there are further improvements that can be made. However, this will require input from bodies other than the NHSBT. A whole systems approach is required. We suggest that key failures in the system, both during the relevant time period and to the present day, are poor information sharing, inadequate education of clinicians, and the siloed nature of clinical practice. I will turn to these failures first, and will then consider issues relating to blood management. We submit that the evidence before this inquiry has demonstrated that very many blood transfusions and the provision of blood products was based upon folk wisdom about the need for such treatment, rather than on clinical justification. Women were given postpartum transfusions in order to get them up and out of bed, rather than being provided with iron tablets or just another day's rest. Surgery was undertaken with excessive use of blood. Blood products were administered for those with bleeding disorders, even when the risk of excessive bleeding was extremely small and alternative treatment would have been effective. This folk wisdom is perhaps reflected most clearly in the 2 not 1 mantra, that if you're going to give 1 pint of blood, you may as well give 2, which on the evidence was a mantra held by clinicians who administered blood, irrespective of their speciality. There was no clinical basis for this. In fact, even the early guidelines warned that blood or blood components should only be given when the benefit outweighed the risk. What this shows is that the culture of an institution and received wisdom can carry more weight than the guidelines sitting by the side of the doctor's desk, and as such is exceptionally difficult to eradicate. For our core participants, this led to unnecessary and inappropriate blood transfusion, which then led to a life-changing infection. Professor Steer spoke of the widespread misunderstanding among obstetricians about the standard medical threshold for anemia in pregnant women. Despite extensive evidence that women in pregnancy will always have a lower level of haemoglobin, which did not necessarily need to be rectified by a blood transfusion, the relevant research studies have not been translated into on-the-ground practice. A number of our clients receive transfusions in this context, and it is, we say, reasonable to infer that this failure to properly educate clinicians in relation to relevant research was at least in part to blame. It's our understanding that this is an issue which continues to the current day, and indeed the evidence before you, sir, supports that. To give another example, Professor Mark Bellamy, chair of the Serious Hazards of Transfusion Steering Group, gave a further example of modern-day malpractice when he spoke of doctors sneakily prescribing 2 units of blood to bring a patient up to a normal blood count. He explained that this was unnecessary, but that the doctor thought they were doing the right thing by correcting the numbers. He went on to say that, and I quote, "Part of the problem, of course, is that each new generation of doctors who come through seem to believe the same misconceptions that the last lot believed, that you've just about beaten out of them. We suggest that in practice, the NHS is still not abiding by the principle which has been in place since transfusion became common after the Second World War, that the safest blood is the blood not given. There were guidelines and guidance on the provision of transfusions which were published from 1958 onwards, but it would seem that they were ignored. Ignored because often only the haematologist had copies and there were no hospital guidelines about them and no education about them, or ignored because they were known about but just were not used. We would suggest that this is not clinical freedom, but the continuation of deeply flawed medical practice which has not been corrected or changed. Not only were guidelines ignored or not adequately reinforced, but when innovations were suggested or promoted which would involve fewer blood transfusions, such as using red cell concentrates and introducing the surgical use of tranexamic acid, these were not supported. The 2021 NHS-BT audit, which Ms Jones referred to earlier, of the NICE quality standards in patient blood management found widespread non-compliance with these alternatives. Lawrence, could we bring up the first document? It's RLIT 0001824. We go to electronic page 4, please. As is shown here on the right-hand side, the first two paragraphs, this audit found that only 59% of patients who are known to have iron deficiency anemia were treated with iron before surgery, and 67.5% of eligible surgical patients were given tranexamic acid, whilst potentially all were eligible. It is not clear from this document whether the patients who did not receive iron or tranexamic acid required a blood transfusion. However, we suggest that it is concerning, particularly in 2021, that these precautionary steps to avoid transfusion are not being taken. This shows that this is not just a problem of the past. That's fine, thanks, Lawrence. So, Brian, we suggest that this demonstrates how deeply embedded practices can prevent appropriate medical care, irrespective of guidance. In this case, we see a fierce resistance to change, not predicated upon advice, but on what has always been done. This is a dysfunctional culture in action. Part of these failures must be ascribed to medical practitioners who were responsible for the management of blood banks. These were haematologists who had often trained or worked in a regional transfusion centre. They were responsible for good blood management. They would receive requests from doctors on the ward for blood and blood components and had the opportunity to question these requests with a view to ensuring compliance with guidance, for example, by asking for details of the reason the patient needed a transfusion and whether alternative treatment had been given or at least considered. However, as we have heard, this was rarely done. These questions rarely asked. The evidence presented to this inquiry, on balance, seems to suggest that they or their team were either not able to discuss these issues with the practitioners administering the blood on the ward or in operating theatres, or they considered that such a discussion was not required or was inappropriate in some way. As we have identified, in order to create a safe system, all parts of that system have to work effectively. Very few individuals were given any training on safe blood use during their medical education, despite administration of blood being a regular occurrence in many specialities. We submit that there was a failure by the NBTS to provide education to doctors and hospitals on safer blood practices. It should have been the body which did so. It seemed to view itself as such, as it published the notes on and later handbook of transfusion. But these documents were not promoted, nor was there any oversight of whether the handbook was being complied with. Many of those who administered blood transfusions and gave evidence to this inquiry frankly admitted that they had never seen it. If the handbook on transfusion was not going to be used, it is not clear to us why it was being produced. Those at the MBTS and many of the regional transfusion directors undoubtedly had real expertise and wanted to convey the importance of limited blood usage. After all, this was set out in the Handbook of Transfusion Medicine. The NHS BTS's submissions do accept that their role included advising on education and audit of transfusion practice, but their approach in reality, as they accept themselves, was largely focused upon supply and not distribution. The NHS BTS accepts that it only had limited resources available during the relevant period to focus upon teaching transfusion practice. Each regional transfusion centre had its own approach to training and professional development. For example, Professor Contreras spoke of regular meetings with hospital staff and training for junior doctors in North London. However, there was no systemic, unified or common approach which sought to provide education as the centrepiece, as an essential cornerstone to blood transfusion safety. The evidence shows that the production of guidelines is not sufficient to overcome folk wisdom or habitual clinical practice. A culture change is required. We suggest that there should be proper research, as Dame Sally Davies identified in her oral evidence to you, as to how to effect behavioural change within the NHS. We agree with core participant Andrew Bragg, who made oral submissions to this inquiry 2 weeks ago, that the NHS is not a learning organisation. We need to turn it into one. Part of this will include behavioural change. In our submission, this would include A, enhancing the effect of good practice within the weight of the law. B, ensuring consistent, adequate, high-quality training. And C, incentivising practitioners by demonstrating how good practice benefits their patients. The impact of poor information sharing and siloed clinical practice went both ways, and in relation to some issues, it was the NBTS that was in the dark. For example, the regional transfusion centre clinicians who gave evidence have been frank in identifying that they seriously underestimated the risks of transmission of hepatitis. There is, we suggest, no excuse for this. The evidence shows that textbooks which were standard for those operating in blood transfusion medicine had identified the risks since the early 1960s. By the mid-1970s, it was well known that non-A, non-B hepatitis could cause chronic illness and cirrhosis. Those treating people with non-A, non-B hepatitis were aware of the risks, but there does not seem to have been any routine input by those specialists into the NBTS, nor was there routine reporting of incidents of transmission of non-A, non-B hepatitis to the blood services. This then played into the limited information given to government and to the clinicians working on the ground in other specialisms. The failure of NBTS to heed this knowledge was significant, given the role it played in terms of influencing other clinical fields, public bodies, and the government in relation to blood transfusion practice. This resulted in failures to make a meaningful contribution to research and data gathering about the emerging risk of non-A, non-B hepatitis, meaning that there was and remains a dearth in the epidemiological understanding of the scale and nature of the problem. Crucially, the failure by NBTS and the individual regional transfusion directors to pay attention to and to seek out the latest research on non-A, non-B hepatitis and other blood-borne viruses resulted in the failure to implement additional measures to mitigate the risk of transmission of this virus. Turning to the blood management systems, in addition to poor clinical blood transfusion practice, we suggest that there was a failure to create and ensure that there was a system of effective blood management within the NHS during the relevant period. We submit that the collection, processing and provision of blood was not as safe as it could have been. There was insufficient monitoring or audit of how that blood was used, who it went to and why, and no real system for reporting when HIV, HBV or HCV was transmitted. The regional transfusion centres were run as independent fiefdoms, answerable to their own regional health authorities, with differing practices and policies. They were, in reality, 14 quasi-independent regional centres and 2 central laboratories without any central coordinating body that had any authority. It meant that blood supply was not necessarily shared across regions and led to a system which did not allow for economies of scale. We submit that it was considerably more difficult and time-consuming as a result to implement patient safety measures and uniform practice across the country. For example, the North London Centre had expert knowledge on AIDS and donor exclusion, yet this was not shared or applied across other centres with sufficient speed. We agree with the submissions of the Collins Core participants that best practice from leading centres could and should have been disseminated and shared. We suggest that the NBTS failed to operate a surveillance system and adequate record-keeping procedures to cover the entire blood transfusion chain. Neither did it have adequate systems for the monitoring, reporting, investigation, or analysis of adverse events relating to blood transfusion. We submit that the failings in the system were known about at the time and are not just clear with the benefit of hindsight. For example, the Department of Health commissioned a report in 1982 which identified serious deficiencies in the control and the movement of blood. In 1984, a health circular issued to regional and district health authorities stated that records kept at RTCs, hospital blood banks, and at ward level must permit the tracing of any unit of blood from collection to transfusion or disposal. However, the evidence before this inquiry shows that this did not happen within the relevant period, or at least not with any consistency. It was known at the time that the system was incomplete and that it was not possible to identify how blood was used, by whom, and when. There was no routine data or audit of transfusion practice in hospitals. As was suggested to this inquiry, had a proper system been in place in the 1970s and 1980s, the NHS and the MBTS would have realised that there were significant infections being caused and that there was near total non-compliance with the guidance on transfusion. The inquiry's presentation on hospital transfusion committees sets out that it was only in 1989 or 1990 that NBTS and government health departments suggested these committees were required. However, it only seems to have been from 1998 onwards that committees were present in most hospitals, and even then, the implementation of their guidance was patchy. Hospital transfusion committees became an important structure to achieve better blood management by way of education, clinical advice, and audit of practice. Dr. Thomas explained how easy it was to change the 2-not-1 mantra practice in his hospital once the Hospital Transfusion Committee was formed. This was because it carried out an audit function, and thus, as he said, it was quite easy to identify the ones that were offending, repeat offenders, if you like. You then focus on those individuals and see if you can persuade them to change their practice. However, even before the committees were set up, there was no reason why other strategies could not have been introduced on a widespread basis. For example, a blood ordering schedule, which could have given hospital blood banks some oversight of the volume of blood being ordered, by which clinicians and when, and could have enabled the identification of excessive blood use. This seems such a simple idea. As I set out earlier, the failure to use fundamental and nationally accepted guidance in the majority of hospital settings led to widespread misuse of blood. However, this was allowed to continue unchecked as a result of the failure to operate audits, which would have identified and could have addressed these issues. There was no leadership for transfusions in hospitals before the mid-1990s. There is no reason why hospital transfusion committees could not have been set up earlier, and there are very many reasons why they should have been. On a national scale, it was only in the late 1990s that there was a better blood transfusion campaign, the implementation of a national committee to advise on blood transfusion, and a centralised body in place whose role was the collection and distribution of blood in the UK as a whole. Before this, there was no such system. We suggest that there has not been any satisfactory explanation by clinicians or others of why it took until the late 1990s for the implementation of this system, rather than it coming into force at the inception of the MBTS or soon thereafter. We submit that this delay reflects an approach to blood collection that encouraged, through the mechanisms of funding and resourcing, the development of a fragmented system operating in silos without a joined-up vision or approach. Part of having a haemovigilance system is having effective records to enable tracing and auditing. There was a wholly incomplete record-keeping system, which meant that it was not possible to effectively trace donations once these had left the regional transfusion centre and were in the hands of hospital blood banks. Thus, there was not and could not be a harmonised system to investigate post-transfusion infections. To describe record-keeping in hospitals as woeful would be an understatement. we submit that there were the following major failures in the system. First, the regional transfusion centres had no responsibility for oversight or audit of the records kept by hospitals. Records of blood transfusions at hospitals were not systematically made. Even if a record was made, it did not always include the batch or serial number of the blood transfused. Dr. Murphy described a 1994 audit at St Bartholomew's Hospital, which examined ward practice both on the day of transfusion and 1 day post-transfusion. The audit found that for nearly 30% of the transfusions given, there was no documentation in the patient's notes. Where a reference to the transfusion was documented, this was usually just a brief note such as, transfuse 4 units of blood tomorrow. Next, where there was a record of the transfusion, there was frequently no reason given for why the transfusion had been required. This meant that audit against best practice could not occur, for example, to determine if blood was being over-ordered or overused by any particular clinician, team or speciality. If kept, the records were typically destroyed 6 to 8 years after treatment in accordance with the relevant record retention policy. We now know that this period is insufficient for a disease which may only present itself decades later. Those drafting the records retention policies failed to recognise that records may need to be examined far into the future for research or because of latent ill health. Hospital record-keeping systems were disorganised, and there were often multiple paper record files kept for one patient. This meant that information may be in 3 or 4 different places. They were often lost when hospitals merged, which has occurred frequently over the past 30 years, or through digitisation, and some records were sanitised by doctors when it became easier for a patient to access information about their treatment, and therefore to read what their clinicians had written about them. The pruning of a patient's notes to that which was essential may have increased the likelihood of blood transfusion-related records being lost or discarded, as they may often not have been set out in the main clinical notes, but on anaesthetic sheets or fluid balance charts, for example. In short, the way in which the system was designed did not encourage accurate recording or ensure retention of documentary evidence of a patient's transfusion. This seems inexplicable, given the importance of traceability if things were to go wrong. There was clear guidance to trusts about the creation of effective records within a hospital blood bank, which were set out in the notes on transfusion medicine and in a 1984 report produced by the British Committee for Standardisation in Haematology. This guidance was routinely ignored or breached. We would stress that many of our core participants are strongly of the view that destruction of their records was deliberate and as part of a conspiracy or cover-up. This belief has been fueled by the lack of candour which our clients have experienced over decades. The perception of deliberate destruction acts as yet another strain on the fractured trust that many core participants and their families have in medical practitioners, and has had a lasting impact on their confidence in NHS services. Some may say that these problems are in the past, but both Professor Bellamy and James Newberger identified that even now, blood transfusion is not part of an electronic patient record. It is usually recorded on paper, which, in theory, gets scanned onto the system at some point. That does not give us or our clients much confidence that this is a system with rigour. The nature of NHS record-keeping systems leaves most individuals searching for records that are more than 10 years old in a state of utter confusion. Copy records are often sent out to them with keynotes missing. Sometimes the missing pages, despite relating to the same patient, are found in a different box or at a different storage location. Often key records are never located and excuses are made, frequently without providing a full explanation of where these important and highly sensitive documents might have gone. Those requesting their records in order to prove they had a blood transfusion have been shocked to find no reference to it, either in the clinical notes, in discharge summaries, or in correspondence with their GP. The inquiry has heard evidence regarding the reasons certain parts of a patient record may be lost or destroyed, as I referred to a moment ago. However, such explanations were not given to our core participants, who, when they questioned the absence of these documents, were usually met with a shrugging of shoulders by those working at the relevant NHS trust. We know that the NHS recognised that record keeping is a problem and has done so for many years. What we don't understand is why it has been so difficult to do anything about it. What is most egregious to us, however, is that despite all of this being well known and understood by those working in NHS services and by civil servants, the trusts and schemes set up to provide financial redress required documentary proof that an individual had received a blood transfusion before payment could be made. This was proof that they knew a significant number of applicants with valid claims would not be able to produce. We would suggest that to construct a system of payments dependent on production of proof which cannot be provided for reasons beyond the control of the individual is Kafkaesque in its design. Our written submissions propose a number of recommendations on the issues I have raised this afternoon. I will summarise a few of these here. The evidence before the inquiry, as I've said, is that there is still not an adequate system for haemovigilance in the UK, and that safe use of blood is often still not seen as a priority. The most recent iteration of better blood transfusion is Transfusion 2024, a 5-year plan for clinical and laboratory transfusion practice in England. Lawrence, could we have the next document up, please? The WITN 7001031. To page 5, please. And then paragraph, if you could highlight paragraph 3, the end of 3.5 from the National Comparative Audit Programme. Just on the, so as we can see, this is a review article about Transfusion 2024, and it refers to data provided by the National Comparative Audit Programme, highlighting that approximately 25% of blood and components are still used inappropriately. This article was published in 2021. The Transfusion 2024 5-year plan sets out 4 key areas for further action. Lawrence, could you do a split screen of the second and third electronic pages? These are outlined here. I won't go through all of them. I believe that they're detailed in the NHSBT submissions. But we support the actions proposed. However, we are concerned that they will not go far enough to address the inadequacies in the haemovigilance system. For example, in his evidence, Dr. Murphy identified that there is no one body responsible for leadership of safe blood transfusion practice. He explained that, as set out in this document, the recommendations of Transfusion 2024 fall to many different groups, including the National Blood Transfusion Committee, and you can see this on the where it says key responsibility of other stakeholders next to each action. So the bodies include the National Blood Transfusion Committee, NHSBT, NHS England and Improvement, Health Education England, Institute of Biomedical Sciences, British Blood Transfusion Society, National School for Healthcare Science, the Royal Colleges and individual NHS trusts, and there are others. However, it is not clear who or which body is overseeing the implementation of measures to improve transfusion practice as a whole. We suggest that this is the continuation of a fragmented system and does not do enough to ensure the joined-up approach required. We are concerned that the plan states that the implementation of the actions in relation to the information technology, and Lawrence, that's just on the second of these pages under C, state that these actions will be subject to agreement on the solution and funding. We would suggest that the failure by successive governments to fund NBTS on a national basis and to provide it with an adequate budget for its research projects acted as a barrier to making change quickly. The proposal of these actions is meaningless if the funding to put them into practice cannot be found. If we are going to adopt the precautionary principle in recognition of the fact that the use of blood is inherently risky, then we have to make it a priority. In our submission, NHSBT should be the body with lead responsibility in terms of education and advice. We welcome the actions set out in the Transfusion 2024 plan, particularly that to strengthen scientific and technical education and training. However, we note that this education is limited to laboratory training. There is no action to implement education of clinicians more widely. We recommend that NHSBT should have a statutory function to promote the appropriate use of blood, and that this should be extended to explicitly embrace informed consent. We have set out in some detail in our recommendations in our written submissions for improvement of the system. They include ensuring that NICE guidelines are adhered to and that steps should be taken to ensure minimal risks of transmission, adopting the precautionary principle you have heard about in written and oral evidence. We have spoken about the failures in record keeping and make detailed recommendations throughout Chapter 5 of our written submissions about this issue. We particularly stress the need to prioritise the development and rollout of a digital patient record. Significant opportunities for patient involvement and interaction with this digital record should be grasped and explored, with a particular view to improving the quality of the patient consent process. This would also assist doctors in fulfilling the subjective element of their duty of care set out in the case of Montgomery and Lanarkshire Health Board. Sorry, Lawrence, could we get that last document back up again? We support the proposal of vein-to-vein electronic tracking that is set out in the Transfusion 2024 action as one of the information technology actions. It's just on the next page. C2, just one up from the bottom. As can be seen, it is described as a plan to drive the implementation of vein-to-vein electronic systems from donation, recipient group, and screen sample, blood collection, administration of blood, and monitoring of transfused patients. However, we do note that this is one of the actions that, as you can see there, states will be subject to agreement on the solution and funding. That's fine, that can come down now, thanks. We consider that secondary care records should be kept for longer than 8 years after the last treatment. A failure to retain records could lead to vital missed opportunities to join up the dots in patient symptoms, which has occurred for our call participants who have had or had viral hepatitis. Further, or alternatively, there should be a process by which a patient is notified and given the chance to request a digital or paper copy of their records in the event that a hospital trust intends to destroy them. GP records should include a flag that a patient has had or is suspected of having had a blood transfusion. We suggest that a targeted infected blood record task force should be created to address the issues mentioned, and also to locate historic records of blood transfusions and add them to patient records. It would be of value to our call participants and others whose record of a transfusion are missing, both because of the trusts and schemes' approach to documentary evidence currently, and because of the likelihood that an individual will be at an advantage in respect of any future compensation scheme if they do have records of their transfusion. It would also have a cathartic function for patients whose doctors did not believe that their hepatitis was caused by a transfusion-transmitted infection and who have faced the trauma of finding out that there was a gap in their records with regards to transfusion history. Particular attention should be paid to examining hospital blood bank records for this missing information and correlating it with patient records. This task force should also identify, as far as possible, where records have been destroyed and by whom, when, and for what purpose, or in what circumstances. The infected and affected deserve more information than they have been given to date. Turning now to donor exclusion and testing. In addition to failures in information sharing and blood management systems, there were failures in the implementation of safety measures at the point of donation, namely testing and donor exclusion policies. The responsibility for the unnecessary delays in implementation of testing does not lie with one single agency, and again, are in part as a result of a fragmented system. The MBTS did not act swiftly. The Chief Medical Officer relied upon the information provided by the MBTS and did not seek to expedite the process. The civil service and the ministers did what the Chief Medical Officer told them. There was no critical friend available to challenge or demand that steps were taken more quickly. We have identified the following themes in the decision-making of the MBTS around testing technologies. Firstly, The NBTS and some regional transfusion centres in particular were affected by a lack of funding, meaning they sought to delay the costs inherent in putting in place the necessary infrastructure to roll out testing. For example, counselling for positive or potentially positive donors. As confirmed by Professor Contreras, there was an attitude of maximum benefit for minimal cost. Second, the NBTS made decisions about testing based on an insufficient epidemiological picture of the prevalence of blood-borne viruses in question. As we have already submitted, this was substantially contributed to by the NBTS's own failures to implement a system of education and information sharing. Third, between 1983 and 1984, the nature and seriousness of HIV was underestimated. Similarly, the underestimation of the chronic and serious nature of non-A, non-B hepatitis persisted until testing was introduced and indeed continued afterwards. Finally, the NBTS system was overstretched and inefficient. It lacked a focus on economical use of blood for patient safety purposes and instead was concentrated on providing enough blood and blood components to meet the needs of the NHS and enough plasma to meet its targets for fractionation. Decisions about testing were made in the context of regional transfusion directors' ongoing concern about inadequate supply. We acknowledge the evidence of multiple regional transfusion directors that the most important factor in delaying the introduction of HIV and HCV testing technology was the fallibility of early generation testing and the absence of effective confirmatory testing. These directors emphasised the ethical ramifications of causing unnecessary distress to the donor if they gave a false positive result. For both HIV and HCV testing, however, we submit that improved technology was very much on the horizon at the points where the early technology was fallible and or in its trial phase. In other words, if an early test had given a positive result, donors would only have needed to be deferred for a short period before improved and or confirmatory testing could corroborate or not the first result. The reasonable ethical concerns could have been dealt with in a way that respected both donors and recipients' interests by ensuring that deferred donors were carefully and sensitively advised of the reason for their deferral and reassured by the offer of further and or more effective testing as soon as it became available. In any event, when it came to testing, we submit that the incorrect balance was struck. The assessment should have been weighted heavily towards patient safety, the protection of lives, and the reduction of chronic illness, and indeed, on an economic level, long-term savings for the NHS by minimising infection. We submit that routine screening for HCV should have been introduced by the 1st of March 1990. This was what Mr. Justice Burton found in 2001 in his judgment in the case of A and others and the MBA. We note that in their written submissions, NHSBT accepted that testing should have been introduced by July 1991, but not earlier. This goes behind the judgment in A and NBA. And as you identified in your questions to Mr. Corey Wright last week, sir, it is a later date than was conceded by counsel for the NBA in that matter, based on the evidence before him. That hearing and the gathering of evidence for it took place much closer to the events in question than NHSBT's submission for this inquiry, and we would urge you, sir, to reject their position on this point and to find, as Mr. Justice Burton did, that routine testing for HCV should have been introduced by March 1990. The continual refusal of those involved to accept this date and to argue that their actions are justifiable demonstrates, we would submit, the willful blindness which we suggest has characterised the approach of the NHS and the state to this issue. Even when screening for HCV was introduced, blood that was already in the system, that which had been processed prior to 1st of September 1991, was not tested. This means that untested blood that may have been contaminated by HCV was included in the supplies held by hospitals for a considerable length of time after the introduction of testing. We submit that this undermines the rationale for the introduction of the cut-off date of 1st of September 1991 for eligibility for the various trusts and schemes. This is of particular concern for some of our clients, and we would ask you, Sir Brian, to find that the cut-off date was artificially imposed without any rational basis. This was evidenced by Richard Gutowski, the civil servant responsible for overseeing the creation of the Skipton Fund. We ask you, sir, to recommend the extension of the current schemes to include those who can demonstrate their infection was caused by a blood transfusion given after 1991. You are aware that one of our core participants, Ms. Chalice, is in this position and that we brought a judicial review on her behalf, challenging the legality of the cut-off date. In Mrs. Justice Stein's judgment in this matter, she left the decision to you, sir, whether to recommend alteration of the current schemes as they operate, and or to recommend that any future compensation scheme is set up without imposing the cut-off date as part of the eligibility criteria. We ask you to do so. In relation to testing to hepatitis B or HBV, we submit that the inquiry has heard limited evidence in relation to the reliability of testing for HBV during the period in question. In December 1972, the UK introduced screening of blood for HBV surface antigen. At least 10 of our core participants received blood transfusions or blood products after 1972, which caused them to be infected with HBV. This was, we submit, a direct result of the fallibility of the early screening tests. It was well known throughout the 1970s and the 1980s that there was a significant risk of transfusion-transmitted HBV infection. It was recognised in the mid-1970s that the tests would identify only around 50% of HBV carriers. Whilst testing technology improved over time, there were still cases of transmission by transfusion in the early 1990s. Despite this, the Department of Health Advisory Committee decided in 1993 that anti-HBC testing, which the research showed would reduce transmission of HBV, could not be justified. It was only in the early 2000s that a more sensitive PCR test was introduced. We submit that there was a failure by NBTS to keep up to date with the developments in tests and to ensure that the most sensitive tests available were employed. On this basis, we consider that the current financial assistance schemes should be adapted to include those infected with HBV and that they should be included in any future compensation scheme. Sir Robert Francis excluded HBV from his recommended framework for compensation because his impression was that generally its effects were mild. However, this inquiry has heard from clinicians treating those with HBV, and most importantly, those infected with HBV who have so powerfully given evidence. We would suggest that you have heard much more than Sir Francis on this issue, which may result in you reaching a different conclusion. In our submission, there are a number of other safety measures beyond testing, and crucially in the absence of routine testing, that were available to the NBTS in order to reduce the risk of infectious donations entering the system. We consider that donor selection and donor exclusion measures used by the NBTS were inadequate in screening out high-risk donors who may have been infected, thus leading to avoidable infections. In summary, the exclusion criteria were insufficient in highlighting the risk factors for AIDS and therefore donors who should defer. We fully endorse the position of Professor Richard Tedder that the donor exclusion for AIDS during the relevant period should have, from the inception of the leaflets, excluded all men who have or who had ever had sex with men, as well as their sexual contacts. The criteria should have excluded anyone who had ever injected drugs at any time. Instead, the language and criteria used was purposefully vague and was overly cautious. It is reasonable to infer that it would have led to some donors who should have self-excluded, continuing in good faith to give blood. Secondly, the evidence before the inquiry demonstrates that regional transfusion centres were too reticent in the way that they promoted this donor exclusion information and managed the process of donor deferral. For example, many regional transfusion centres were reluctant to send the AIDS donor information leaflet to their donors with calling cards and instead chose to have the leaflet merely available at donation sessions. These often took place in workplaces and other large industrial settings where it is unlikely that individuals would have wished to reveal private or personal information. With the exception of a minority of centres, notably North London, most were not in favour of too close questioning of donors as to their sexual activity, out of concern that it might be counterproductive. The evidence, however, shows that these fears were unfounded. To the contrary, parallel work engaging with the gay community could lead to the understanding and support of the communities the NBTS was seeking to exclude or defer. Professor Tedder described this as a meaning and useful interrelationship and exchange of views and advice, bilateral advice on how to find the best way forwards. Crucially, as those with ministerial responsibility for these leaflets accepted, notably Lords Fowler, Clark and Glenarthur, their publication was improperly delayed. This delay appears more starkly when contrasted with the Scottish approach. Turning now to our fifth issue, our fifth key theme, diagnosis and treatment for those infected. Our core participants, having been infected with blood-borne viruses, then had this harm compounded by a litany of further failures from the medical system in terms of their diagnosis, care and treatment. Many persist to the present day. We urge the inquiry to recommend action to address these inadequacies. We submit that it can be reasonably inferred that countless victims of infected blood were never diagnosed and died without knowing or are still out there undiagnosed. These patients were lost to the system. We submit that not nearly enough has been done to proactively try to find them. For many of our core participants who are not frequently subject to tests or assessment by specialist clinicians and so were reliant upon primary care to identify possible HBV and HCV infections, there were often very long periods of time between their symptoms being recognised and their infection being diagnosed. We have set out in our written submissions, annexes 5 and 6, if you wish to look, the period between infection and diagnosis, which was for most at least 5 years, and in some cases was well over 30. Had they been provided with adequate information about the risks of transmission, they may well have recognised the signs of hepatitis or been able to discuss this with their GPs or others earlier, recognising that this may have come from the blood transfusion. They could have been tested in as early as 1991, when routine screening became available, and could have adopted lifestyle changes to mitigate the long-term damage to their health. Instead, they spent years, and sometimes decades, with a wide variety of severe symptoms, but without diagnosis, and therefore without appropriate treatment. We set out, again in the annexes of our written submissions 2 and 3 this time, the symptoms described by our core participants in their witness statements. The inquiry has heard extensive and distressing evidence of these symptoms, and I don't propose to list these out or put them on screen unless it would be helpful for me to do so. Suffice to say that they are wide-ranging and have been debilitating for our clients. We submit that the failures in treatment and care and support were a result of a system that failed to listen to its patients, making assumptions about their symptoms based on prejudiced stereotypes, and was woefully under-resourced in terms of information about the infected blood scandal, blood-borne viruses, their symptoms, prognoses, and the available treatment options. Steps were taken to carry out a look-back exercise, however, this was inadequate. Principally, the look-back took far too long to be set up, and its success was doomed because of earlier record-keeping failures. Moreover, and once again, potentially infected recipients were not prioritised or treated as autonomous individuals, with clinicians giving a kind of therapeutic exception option to not inform them that they had likely received blood. It took many of our clients until this century or even the past decade to receive a diagnosis, while those currently in charge of the NHS England Hepatitis C team, in terms of the elimination ambitions, seem to think otherwise. We suggest that it is still the case that there are many people who have been infected with hepatitis C via a blood transfusion who have not yet been diagnosed. Samantha May, who has been involved with running the Hepatitis C Trust's helpline for over 20 years and who we suggest has an almost unrivaled understanding, identifies that this is still an issue. Between 2019 and 2023, some 110 people who contacted the Hepatitis C Trust helpline had received a recent diagnosis of HCV, where the only identifiable risk factor was blood transfusion. Since the beginning of January this year, she has received calls from 3 newly diagnosed individuals who were infected via blood transfusions over 31 years ago. She has also informed us that as a rough estimate, she receives 2 calls per month where the only of people recently diagnosed with HCV, where the only risk factor is a transfusion. Whilst it is a diminishing issue, it is vitally important that those who may still require treatment are urged to come forward. Unlike in other countries, there has never been a drive in the UK for the general public or those of a certain age to be tested for HCV. We suggest that this should have happened and should still take place. We submit that the evidence of those who sought treatment and diagnosis highlights the following concerns with practice and procedure within the NHS, which we suggest is still the case. Ignorance on behalf of the primary care providers about the risk of HBV and HCV to individuals who have no history of drug use and do not come from a high-risk country. This leads to a reticence or an outright refusal to refer the patient for viral hepatitis testing. This lack of knowledge has prevented effective testing and treatment and still continues today. There are dozens of examples before the inquiry of people, often women, being told that they don't need a test on the basis that they don't fall into one of the high-risk groups. Even when blood tests return abnormal liver function results, referrals for testing were not made. There were assumptions made, assumptions which even at the time did not fit the presentation of the patient. Instead, the abnormal results should have been investigated. The ignorance of primary care providers and their lack of understanding about infected blood and blood-borne viruses led in some cases to a diagnosis not being communicated because the GP did not feel able to provide appropriate information. The lack of education and training of GPs about these issues created a blind spot in terms of diagnosis, treatment and care. The way that diagnosis was communicated was often very poor and was delivered with a notable lack of detailed information about prognosis and treatment options. A diagnosis was often communicated in a heavy-handed and frightening manner, with very little emotional or indeed practical support. Often, diagnoses were given without explanation or understanding of the sensitivities that should come with communicating a stigmatized disease. For example, the news was delivered by letter or telephone call out of the blue and without nuanced and sensitive discussion. Almost all of our call participants have said that they were not given sufficient information to manage their conditions or to understand the risk to others. Almost none were given information about useful support groups or information that they could access. These failures cannot simply be ascribed to a lack of scientific knowledge. They were as a result of poor communication skills and ignorance due to a lack of education and training. We would submit that if GPs did not feel confident about discussing these issues with their patients, referrals should have been made to those who could have explained matters clearly and with sensitivity. A feature of the poor treatment and care our call participants have experienced is stigma, even at the hands of the medical system and practitioners themselves. Many of our call participants suffered a general lack of compassion and dignity, with their viral status being announced or disclosed inadvertently or not in a non-private setting, such as a ward or waiting room. Many of our call participants report their confidentiality and dignity being compromised by visible skull and crossbones stickers on their medical notes or other non-discrete means of identifying that they were an infection risk. Similarly, many report being deprioritised for treatment, often put to the end of an operation list, or being refused treatment altogether because of their viral status. This appears to have been particularly common among dentists. This was wrong. Hepatitis expert Dr. Jeffrey confirmed that standard precautions for hygiene and safety in hospitals should apply for those with hepatitis and HIV, apart from rare and specific scenarios, such as in a renal dialysis setting. Some of our call participants state in evidence that they were told they were lucky to receive treatment for viral hepatitis. This is, we suggest, a stigmatizing approach to treatment, singling out a patient group as somehow unworthy of treatment that has been properly allocated to them. We submit that many of our female call participants, on top of being patronised and belittled when giving birth, were then patronised and belittled when they presented with symptoms. Whilst this inquiry is not about gender discrimination, it reveals the widespread and systematic discrimination in the provision of medical treatment to women. Furthermore, and as touched upon by Ms. Gollop, Clients with bleeding disorders or HIV or hepatitis C were encouraged not to have children, to be sterilised, and were seen as tainted if they were carriers. Given that a significant number of our clients were given blood during obstetric and gynecological treatment, we draw your attention in particular, sir, to recommendations we make in Chapter 8 of our written submissions in relation to gender equality. Could we put these on screen, Lawrence? It's SUBS, I think that's 6059, and it's page 432 and 433. So it's, yeah, the recommendations from there, and then it carries on to the blue text at the top there. The first ever women's health strategy for England was published by the Department of Health and Social Care in August 2022. Dame Leslie Regan, a distinguished obstetrician, is now the Women's Ambassador for Healthcare. We would ask that you, sir, make the recommendations to her, which can be seen on the screen. As you can see, these recommendations relate to blood transfusion practice, women's experience of patronising care, disparities in treatment for HCV, HBV, and HIV, and training of clinicians on the bias in the diagnosis and treatment of women's health. Thank you. Turning to treatments, particularly for hepatitis C, we do not need to reiterate in any detail the horror of the first stage treatments for HCV. It is sufficient to recall that Emma Prescott, specialist thalassemia and hepatitis C nurse, described interferon as the worst drug she has ever had to give to patients. Again, whilst we recognise the enthusiasm for any form of treatment, we suggest that the horrendous side effects and relatively poor success rate should have led to more conversations about the benefits of this treatment, which the evidence of clinicians has recognised were not always had. Many of our core participants experienced a significant delay in receiving the new direct-acting antivirals. This only changed in 2017 when the drugs became funded via NHS England and a central commissioning service. We suggest that, again, there were failures of communication between doctors and their patients about why they were or were not eligible under a system of rationing. No consideration appears to have been given to prioritising those with infected blood and or explaining why they would not be so prioritised. We would also identify that there needs to be a monitoring of side effects on an individual patient and on a national scale. We would ask you, sir, to identify that the current services for follow-up and monitoring after treatment for HCV, where there has been a sustained virological response, is patchy. There is no consistent clinical practice, and many of our patients have no clinical surveillance at all. We make recommendations for systemic and consistent follow-up. We recognise that resources are precious and scarce. However, these recommendations are made in light of the experiences of our core participants over many years and their quite reasonable concerns, which are palpable and understandable about the damage HCV may have caused to their body and their increased risks of end-stage liver disease. We also submit that there is the clinical evidence to suggest that such is warranted. This was amply explored by multiple experts, as is set out in our written submissions. We do not intend to repeat this evidence today. We submit, therefore, that all those who contracted HCV through infected blood should receive regular monitoring and screening as frequently as possible to mitigate their continued risks of developing cirrhosis and liver cancer. To the extent required, a bespoke policy should be in place that reflects the historic wrongdoing and failures to diagnose victims of infected blood over decades and the heightened risks and anxiety they therefore face. Our recommendations on these issues are based on what the hepatitis expert group said all patients were entitled to expect as best practice. Moreover, it would be likely to save costs overall. There is evidence among our core participants of patients falling outside the system after successful or failed treatment, particularly with early interferon treatment. There should be a conscious effort to recall such patients, as they may have cirrhosis or be at risk of liver cancer. Therefore, they may still be clinically entitled to newer treatments, monitoring, or indeed other services such as palliative care. There should be a conscious effort. Another overriding theme from our core participants' evidence is the failure of their treating medical practitioners to provide care and treatment for all the manifestations of their HCV pre or post-treatment in a joined-up way. The experience of most of our core participants is that clinicians who are not HCV specialists are not even aware of basic information about HCV, nor the latest research around its various extrahepatic manifestations and its nature as a multi-system disorder. We consider that a model of care specifically for people with HCV is necessary, which ensures joined-up care and continuity of support. This should be managed on a multidisciplinary basis, which embraces the patient's entire physical and psychosocial needs. This multidisciplinary model would benefit both patients and doctors in the sense that it would allow medical professionals to make more collaborative, patient-driven, supported and evidence-based decisions. It would also allow for cross-fertilization of knowledge, including between specialities. While we submit this is good practice in medicine generally, it is all the more vital for our clients because of the multi-systemic nature of their conditions and the tendency for them to fall through the cracks of the system or have their multiple conditions and treatment inappropriately coordinated. This was a manner of delivering care that was praised by multiple expert clinicians throughout this inquiry. In our written submissions, we make detailed recommendations for the implementation of regional HCV hubs and integrated care, facilitated by specialist HCV nurses. This is a crucial part of the redress those infected are entitled to and is essential for rebuilding their trust in the NHS. We suggest that none of this is more than good practice would expect in any event. This approach will in fact save time, money, and NHS resources. It will avoid the siloed care, which is time-consuming for patients, and inefficient use of clinicians' time, and treatment pathways, which are inappropriate for a multi-system disease. As well as support for physical symptoms, we submit there is a significant need for specialist psychological support. There has been a paucity of such support to date. The woeful attitude of NHS England to the provision of specialist psychological support as part of the trusts and schemes was explored in the November hearings, but did not fill our core participants with optimism that, absent a clear steer from you, Sir Brian, anything would happen. There has been no dedicated service for those infected with HCV by blood transfusion and their families. By contrast, the inquiry has heard and received evidence of HIV and haemophilia-specific services. The limited services some of our core participants received through the trusts and schemes were inappropriate, inadequate in the length of treatment, and not tailored to the impact of infected blood. The justification for such a service has emerged from a vast range of evidence to the inquiry, including the evidence and recommendations of the psychosocial expert group and the fact that HCV itself can cause mental health disorders. We therefore suggest that it is essential that ongoing treatment for our core participants includes psychological input for those who want it. This should be offered as a matter of routine upon diagnosis with HPV and HCV as a result of receiving infected blood or blood products. This should be funded and not limited to the usual NHS offer of 12 sessions of CBT. It could include support groups or, where appropriate, family therapy, considered on a case-by-case basis. Family members of those infected should be offered psychological support, as has been done successfully in Ireland. As Samantha May and many of our CPs have explained in their evidence to the inquiry, psychological support should be targeted towards the needs of this group. It is essential that professionals providing psychological support or counselling for this group understand the history of NHS-infected blood and therefore the nature of the trauma, sense of injustice and lack of trust in the NHS and medical professionals. We understand that there is specialist counselling available in Wales, Scotland and Northern Ireland, but not in England. We recommend centralised commissioning through NHS England and delivery via the regional hubs. Treatment for the infections should not be viewed as the end point of psychological difficulties for those suffering with HBV or HCV. Access to HCV support should not be time limited and should be provided on the basis of need without unnecessary access hurdles. In addition to any psychological service, there is a need for day-to-day support via groups, help and information phone lines to assist people to manage the impact of living with the infection. The Hepatitis C Trust provides a great deal of support through their information lines, without any form of government assistance at present, something which may not be sustainable in the long term. The inquiry may wish to consider whether such services should be funded through an NHS grant. Patients from minoritized ethnic groups, including those who have sickle cell disease and thalassemia, have faced stigma, inequality in care, and discrimination on the grounds of their race and ethnicity. They therefore should be provided with specialist psychological support that acknowledges and is informed by the unique obstacles they have faced. Very few of our core participants have received or are receiving any palliative care at all, a phenomenon that the palliative care group considered was not unusual given the low priority this had had within liver treatment until recently. We consider that good palliative care is what those of our core participants who have advanced liver disease deserve and require, and we therefore ask you to endorse the conclusions of the palliative care expert group report and to make recommendations so that palliative care is seen as standard in the care of advanced liver disease in the way that it is in respect of other diseases. In summary of the issues I've covered, sir, we consider that the failures which led to the infected blood scandal were systemic in nature and were created by every part of the system which provides medical care to individuals in this country and which pays for and organises it. There was a distinct lack of education about blood-borne viruses, but in particular hepatitis B and C, during the time in question, their signs, symptoms, and long-term impacts. But as we have identified, there are also wider failures in treating patients with respect and dignity and being open and candid with them. Again, there are some basic changes which should be made. There is currently no formal system for making guidelines available across the entire NHS, nor is there any duty upon a clinician to understand good practice. There should be a system for promulgation of and education in good practice and to keep clinicians up to date. Much of the material is still aimed at the specialist rather than being set out in bite-sized chunks for consumption by the doctor who may need to know the conclusions rather than the research biases. There is still a hierarchical culture which involves learning by see, do, teach, which we would suggest promotes worst practice, bad habits, and the folk wisdom we spoke about earlier. We therefore make detailed recommendations that there be a robust overhaul of medical education, in particular education related to HCV, supported by a public information campaign to increase understanding and awareness of both doctors and patients, which we refer to at Chapter 5 of our written submissions. That concludes my part of the submission, sir. I note the time. As we discussed, I think Ms Jones needs about 30 minutes, so...
Well, I think we're going to hear Ms Jones tomorrow morning.
So tomorrow, sir, we'll conclude the submissions on behalf of the Lead Aid core participants, hearing from Ms Jones again. And then we will be hearing Mr Williams and Mr Howells on behalf of the core participants represented by Watkins and Gunn solicitors, with a particular focus there, therefore, on Wales and Northern Ireland.
Now, they've been given a start time of, what, 11:30 on the programme?
Yes.
And is that going to be maintained, or will they follow?
It may be a little earlier. If Miss Jones is in the region of half an hour in the morning, we'll probably take a slightly earlier break, or we'll have to see how things go tomorrow.
Well, we can sort that out in the morning.
We can.
Rather than determine it now, but at least it's a possibility. So for those who are interested in particular, in the Watkins and Gunn submissions, it may not start at 11:30. It may start beforehand. That's the only message you need to take back with you. And those watching online who may be here, the same.
Yes.
Well, thank you very much. Thank you very much, Ms Morgan, for stepping in. It's not an easy task, and thank you.